Hello everyone, my name is Sunanda Rajegowda. I am a family nurse practitioner and I will be presenting my scholarly project Diabetes Self-Management Education and Support to Improve Type 2 Diabetes. This project was completed with the assistance of Dr. Gail Petrov, DNP Chairperson, Dr. Maria Snell, my Nurse 707 Professor, and community member Dr. Manjusha Meprum. Diabetes mellitus. Diabetes is a metabolic disorder that affects the body's capacity to metabolize and absorb glucose due to a lack of insulin or insulin resistance. Children commonly present with type 1 diabetes and adults commonly present with type 2 diabetes. Aim of this project. The Quality Improvement Project aimed to evaluate the effectiveness of a nurse practitioner-led American Diabetic Association informed Diabetes Self-Management Education and Support Program on the self-management of patients with type 2 diabetes mellitus over 6 months. Primary study endpoints included serum hemoglobin A1c, creatinine, triglyceride levels, and glomerular filtration rates. Background. Diabetes mellitus is a global health crisis, claiming 537 million people worldwide as of 2021 and affecting over 10% of the world's population in 2021. By 2030, the number is expected to reach 643 million, projected the possibility to reach 1.3 billion by 2050. Diabetes accounted for at least $727 billion in medical costs in 2017. 12% of all adult healthcare expenses on diabetes. According to the National Diabetes Statistics Report, there are 84.1 million people in the US who have prediabetes and 30.3 million people who have diabetes. To address this, healthcare providers should focus on diabetes self-care management education and support as recommended by the American Diabetes Association to improve patient outcomes, self-management, and quality of life. Diabetes is a serious condition linked to high death rates and disability. To prevent complications, it's crucial to manage it proactively. This involves taking medications as prescribed, making lifestyle changes like healthy eating and exercise, regular monitoring of blood sugar and other health markers, and staying under the guidance of a healthcare provider for close supervision. Significance. Type 2 diabetes mellitus has increased significantly as a result of lifestyle changes brought on by urbanization, globalization, population aging, socio-economic inequality, and convenience food marketing. According to the World Health Organization, chronic illnesses are the leading causes of early mortality, morbidity, and disability, accounting for 74% of deaths in 2019 and 62% of the total disease burden in 2018. In the US, where the healthcare system is already stretched, nurse practitioners are in an excellent position to support diabetic patients. They can supervise care, help manage the illness, and provide guidance. This study tested how effective nurse practitioner-led education programs are in helping patients with type 2 diabetes to manage their condition. Evidence suggests that continuous guidance to the patients not only improves survival but also improves quality of life and social productivity of the patients, improving their overall social well-being. The literature. Diabetes Self-Management Education and Support, based on the American Diabetes Association guidelines, is a structured, patient-centered approach to manage diabetes. It aims to empower individuals by providing education on essential aspects such as healthy eating, physical activity, blood glucose monitoring, and medication management. DSMES also considers the interplay of various factors, including social, emotional, and cultural influences, to create personalized care plans. By addressing these factors, DSMES help patients to make informed decisions, improve the self-management skills, and enhance their overall quality of life and clinical outcomes. Research consistently highlights that diabetes self-management education and support is effective in improving health outcomes for individuals with diabetes. A systematic review by Al Arbi found that DSMES significantly improved glycemic control in patients with type 2 diabetes by reducing the hemoglobin A1C levels ranging from 0.57% to 1.13%. Evidence also suggests that DSMES enhance self-care behaviors including medication adherence, physical activity, and dietary changes. Additionally, DSMES also has been effective in reducing the risk of diabetes-related complications and hospitalizations, leading to the cost savings in healthcare. A nurse practitioner-led diabetes self-management education and support intervention integrates well with Pender's health promotion model to enhance patient engagement and improve their diabetes outcomes. It incorporates the key constructs of the model: the perceived susceptibility and severity. A nurse practitioner-led DSMES counseling increases patient awareness about the risks associated with diabetes, including complications like cardiovascular disease, neuropathy, and kidney failure. Perceived benefits. Nurse practitioners emphasize the positive outcomes of optimum diabetes management, such as improved blood sugar control, a reduction in complications, and enhanced quality of life. Perceived barriers. Nurse practitioners identify and address patients' barriers to self-management, such as financial constraints, lack of social support, or difficulty in adapting the new behaviors. They offer practical solutions and emotional support to reduce these barriers and make self-care more feasible for patients. The study employed a quantitative retrospective chart review to assess the metabolic profiles of the patients with type 2 diabetes mellitus before and after receiving the diabetes self-management education and support intervention. The research study was conducted in a primary care clinic. The review involved examining the electronic medical records of 40 patients. Data was collected on key clinical endpoints including hemoglobin A1C, triglycerides, creatinine, and glomerular filtration rate before and after the intervention. This quality improvement project consisted of interventions implemented over time using 4 cycles. That's PDSA cycle, which is a plan, do, study, and act cycle. The clinic's EMR was used to gather the data. The following is a detailed step of the project's protocol. Obtain the list of patients with this type 2 diabetes from the clinic manager. Diabetes self-management education was implemented. Patients' identifiers were not disclosed for this project. The project focus was a retrospective chart review. The diabetes-focused bundle care visits were 40 minutes long for type 2 diabetes patients, and the author is a certified family nurse practitioner implemented diabetes education. Intentional diabetes self-management education and support for type 2 diabetes patients was utilized as a diabetes education tool based on American Diabetes Association guidelines and American Association of Diabetes Education 7 behaviors to implement effective diabetes bundle care. The data collection was initiated as soon as Maryville University IRB approval was granted. Pre- and post-study data was collected from the EMR 6 months before and after the implementation of diabetes self-management education. A numerical number was assigned to each EMR used in the project. On the data collection sheet, the EMR was given a number. The data collection sheet gathered the minimum information required to meet the project's objectives. The data collection process did not involve the inclusion of patient identifiers. The researcher reviewed the pre-study and post-study data of the 40 expected EMRs on the written list provided by the clinic to manage. The data collection process was conducted after reviewing and collecting the required data of the 40 EMRs. The intervention comprised a nurse practitioner-led one-to-one 40-minute counseling session with each participant diagnosed with type 2 diabetes. The core components of the intervention were DSMES-based knowledge informed by the American Diabetes Association latest guidelines. All the patients had the chance to interact with the nurse practitioner and also clarify their queries and misconceptions about the recommended treatment regimen. Prior to commencing the project, IRB approval was sought from the University of Maryville, Institutional Review Board, and throughout the project, principles of anonymity, confidentiality, and adherence of HIPAA were maintained. The data extracted from the EMR was the minimum required data to achieve the project's objectives. Only de-identified information was on the data collecting form. The necessary data was retrieved from the chart on the data collection sheet. The data collection sheet did not contain any patient identifiers. The de-identified data collecting sheet was kept in a password-protected file, with the only nurse practitioner having access to abide by the Health Insurance Portability and Accountability Act privacy rule. The sample of 40 patients comprised of 22 males and 18 females, and all selected via the electronic medical record. Approximately 40 patients were expected to undergo the DSMES intervention, and as a part of this project, patients' EMRs were reviewed for data collection. Asian, African American, and Hispanic patients made up the most of the patient population. The patients' age ranged from 18 to 65. The research project involved people of all genders in data collection, patients with a documented diagnosis of type 2 diabetes who received the intentional diabetes, self-management, education, and support intervention. The pre and the post labs results for the project were gathered using an Excel data collection spreadsheet. For analyzing the data, descriptive was as well as inferential statistics were calculated. For descriptive statistics, means and standard deviations, median and the interquartile ranges, as well as normality checks were done for all the continuous variables. Since none of our outcome variables were not normally distributed, we used a non-parametric substitute Wilcoxon sign rank test to analyze the differences between hemoglobin A1C, triglycerides, creatinine, and GFR of the patient before and after the intervention. Throughout the inferential and descriptive statistical analysis, alpha was set at 5% and hence a p-value less than 0.05 was considered as a significant. The result of this study was also as hypothesized. The hemoglobin A1C level, triglycerides, creatinine, and GFR all showed improvement at the end of the intervention. However, the results were statistically significant for hemoglobin A1C, triglycerides, and creatinine, but not for the GFR. Hence, it can be safely concluded that at a 5% level of significance, the glycemic control, cardiovascular risk factors, and renal complications, all parameters were responded positively towards the intervention. In this project, the differences in the outcome variables before and after the interventions were achieved with the optimum statistical significance. Despite the gap of 6 months, achieving the desired outcomes reflects the goal's accomplishment. Descriptive statistics were used to organize, display, and describe the participants' characteristics, compare the distribution of the continuous scale variables, and also to determine the measures of tendencies of each outcome variable. Out of total 40 participants, there were 22 male and 18 were female patients. The baseline and post-intervention values of hemoglobin A1C, triglycerides, creatinine, and GFR were non-normally distributed. Descriptive statistics are displayed as figures like histograms of all the variables. In this picture, the hemoglobin A1C was found to be significant. There was a significant difference from pre to the post-test. Patient test results were compared before and after the intervention workshop. On average, patients performed better after the intervention than before. Limitations. The study had several limitations due to its design, the small sample size, and a single-center design limited the generalizability of the results. The difference between the outcome variables was not adjusted for confounding factors, which may have influenced the outcome variables. The retrospective nature of the study also prevented the establishment of the cause and effect temporality. Therefore, the results should be interpreted with caution. Also, the physician, clinic manager, nurse practitioners, and support staff worked closely with the participants to successfully improve the outcomes reported by the type 2 diabetes mellitus pair participants. The clinic's medical staff underwent some changes which were found to be the only major obstacle to this project. The findings of the current study concur that pre-established hypotheses and also are aligned with the previous literature. We hypothesized that NP-led DSMES education would improve the diabetes patient's glycemic control, cardiovascular risk factors, and renal complications. Hence, the results rejected the null hypothesis and yielded the patient's metabolic profiles responded positively to the DSMES education. These findings are aligned with the previous studies. However, there may be some differences in patient population sample size study, setting that is a context of the clinic. These results remain largely comparable to each other. When compared to the previous research, the study findings were consistent. Without the right information, diabetic patients may have a harder time to take care of themselves and manage their disease. Improved knowledge of modifiable risk factors can lead to better overall care for patients with type 2 diabetes. DSMEs are also regarded as an essential part of diabetes care, in addition to the pharmacological options for diabetes management. Previous research has demonstrated that the patients can be effectively prepared for diabetes control and regulation through a group-based education and also support. The study has several implications for practice as well as for research. It can save the cost of our already stretched healthcare system because it empowers the patients and builds their capacity to take care of themselves and reduce their burden on the hospital system, thereby efficiently expanding the role of nurse practitioners. Based on the study findings, we recommend several actions to improve diabetes management and chronic illnesses care. First, expanding the implementation of nurse practitioner-led educational programs for diabetes patients could enhance health outcomes and reduce complications on a wider scale. Additionally, developing culturally tailored diabetes programs could increase engagement and effectiveness, particularly within the ethnically diverse population. The research study utilized Pender's health promotion model to improve patients' healthy behaviors, commitments, and adherence to the treatment's health by decreasing complications. The project identified the factors that impact treatment adherence in type 2 diabetes patients. Pender's health promotion model principles provide a strong structure for developing the effective diabetes self-management education for patients with type 2 diabetes. The health promotion model successfully improved the self-management behaviors of type 2 diabetes patients. Addressing key components such as health promotion behaviors and commitment to a plan of action by educational intervention enhanced patient engagement and improved the patient's health outcomes. The study results indicated that improvement in self-care behaviors improved the patient's diabetes health condition after the implementation of the intervention by supporting a theoretical framework. In conclusion, implementing the DSMEs in diabetic patients and offering early education, intervention, and prevention methods have proven to handle diabetes holistically and reduce its effects. Diet, physical activity, blood glucose monitoring, adherence to medication regimen, a good problem-solving skills and coping skills, and also risk reduction behaviors are the primary behaviors connected to managing the diabetes self-care. Ongoing self-care will lower the probability of diabetes complications occurring. Most patients do not employ sufficient self-care strategies such as following diet, engaging in a physical activity, and regulating blood glucose levels. The project will aid in defining the practically implementable best practices for type 2 diabetes management and for avoidance of both acute and long-term consequences of diabetes by practitioners in clinical practice. This pragmatic approach makes it easier for healthcare professionals in settings with limited resources to adopt cost-effective, evidence-based diabetic care. That concludes my presentation on my diabetes self-management education and support project to improve type 2 diabetes. Thanks for attending and viewing my presentation. I would be happy to take questions now. Thank you once again. And I have the reference list here.